right, Kevin, I think that we are ready to go ahead and get started. Thank you so much all for joining for this webinar. I'll be continuing to admit people in as we get started.
Well, thank you everyone and welcome. This is our seminal Eliminate Tobacco Use webinar, and we're glad you're able to join us today. Kevin Everett, I'm a faculty member at the University of Missouri in the Department of Family and Community Medicine and have worked in tobacco control for almost 2 decades now. We have a new project called the Missouri Eliminate Tobacco Use Initiative that is about halfway through year 1 and of a 3-year project. We are collaborating with MD Anderson, who has sort of the original founding institution for Eliminate Tobacco Use. In Texas, they've been doing Eliminate Tobacco Use for about going on 5 years. And the core elements of the Eliminate Tobacco Use initiative are to address policy, cessation, and prevention, and to do that in college campuses and in health systems. And so we're really pleased today to be able to bring a webinar of some experts who have been delivering tobacco cessation services in health systems. In addition, we're also able to cover areas around the billing and coding that takes place in order to receive reimbursement for tobacco cessation services. So with that, I'm going to turn it back over to Josie, who will introduce our speakers.
Hi, my name is Josie. I'm one of the student research assistants with Dr. Everett and Jenny Chadwick for the summer and into the fall. So we have a great lineup of speakers today. We're going to start off with Anne DiGiulio. She is the National Director of Lung Health Policy at the American Lung Association. She'll be followed by Rick Cagan, the Director of the Behavioral Health Tobacco Project over at the National Alliance on Mental Illness, Kansas. Third, we have Dr. Kim Richter, the Director of UKanQuit Cessation Services over at the University of Kansas Hospital Tobacco Treatment Service. Fourth is Genevieve Casey, one of the UKanQuit Tobacco Treatment Counselors over at the University of Kansas as well. And then lastly, we'll have Jim Bronner, our community educator and a tobacco treatment specialist trainer over at Cox Medical Center in Springfield, Missouri. So we will start off with Anne.
So much, Josie. I'm really excited to be here today. As Josie mentioned, my name is Anne DiGiulio. I'm the National Director of Lung Health Policy at the American Lung Association. And I'm going to talk to you today about tobacco cessation. Okay, so first kind of go over quickly, and I promise I will be quick. And I think there's going to be a lot of time for Q&A at the end, and I also have my email address if I don't answer any of your questions now. So I'm going to go over some quick coverage requirements, kind of more from the federal level, as opposed to what's, so we'll do that real quick. And then I'm going to talk a little bit about some quality measures. So really kind of ways that hospitals and health systems can, it sounds like I'm muffled. Is anybody else having trouble hearing me? Okay, we're just going to go then. I'm sorry if you've got questions, happy to talk with you on the phone later. And really kind of quality measures is ways to incentivize providers and health systems to really utilize some of these cessation things. And then kind of recognizing the moment that we're in with COVID-19, the COVID-19 pandemic, talking a little bit about cessation from a telehealth perspective. See if I can do that in 15 minutes. So the tobacco cessation benefit. So when we talk about a tobacco cessation benefit, we're looking at the Treating Tobacco Use and Dependence Public Health Service Guidelines. It includes all 7 FDA-approved medications and all 3 forms of counseling. This has been reiterated by a number of professionals and the Surgeon General multiple times. All these treatments are considered first line to treat tobacco dependence. Additionally, when we look at tobacco cessation coverage, we also look at some barriers to accessing care. While these might not necessarily look like really bad barriers or really unachievable barriers from a higher income category or group of people, from a lower income group of people, especially Medicaid enrollees, things like cost sharing can be really impactful, as well as things like required counseling or stepped care therapy, meaning that you might need to try on one medication and fail before you can do another, or even required counseling. While we know that that's the best way to quit is both counseling and medications together, requiring somebody to do phone counseling that might have limited minutes on their phone, or might need childcare to get to a group class can really be challenging. So we really want to try to encourage everybody to quit the best way that they can, and hopefully that'll be with both counseling and medications, but if not, we don't want to deter anyone. And I've got some specific Missouri information. I know a lot of us are from Missouri. I know there's some Kansas people on the call too. So, but just in these numbers are not necessary. I mean, they're specific to Missouri, but the Medicaid smoking rates are very high in general. Missouri's Medicaid smoking rate is 44.5% compared to 12.8% of the general US population. And about just under 24% of Medicaid enrollees nationally. Obviously, there's a huge cost to the state Medicaid program. Again, this is consistent across the country. But the really good news, like this is a bad news slide, but there's good news on it. So the bottom of it is, we know that most people want to quit, including most Medicaid enrollees. And we know over half of them try to quit every year. So there's good news, we can help people. So now I'm going to go into some of those coverage requirements. So for standard Medicaid, again, from a federal perspective, there's essentially the standard Medicaid program. So that's what Missouri has right now. The only thing Kansas has, we'll get into Medicaid expansion in a minute, which is super exciting because Missouri will have Medicaid expansion very, very soon. And yes, that totally deserves a round of applause. But the essentially the standard Medicaid population, and so these are the people that would have qualified for Medicaid prior to the passage of the Affordable Care Act. Essentially, tobacco cessation medication should be required. The provision does not address counseling. It does not address barriers. So you can still charge copays for the poorest of the poor, while you can't do that for higher income populations, which we'll get to in a second. The one caveat to that is pregnant women in Medicaid. Beginning in 2010, all pregnant women in Medicaid were required to have a comprehensive cessation benefit with no cost sharing. And that is written into the law. So there's not a lot of room for interpretation there. And that does include all of the FDA approved pharmacotherapy as well as all 3 forms of counseling. Private insurance is a little bit different. There's a number of protections for private insurance, which are listed there. One of the most important is that essential health benefits, or the EHB. And the EHB are essentially all the services listed here. There are 10 of these essential health benefits. Every plan in most private plans, including any plans sold in the exchange, has to cover these. The one that we're going to talk about today is this preventive and wellness services and chronic disease management, or the preventive services provision, which if anybody's ever talked to me about tobacco cessation, I will go on at length for. Which essentially means, again, as I mentioned, it's for almost all private plans, including any plans sold in the exchange, small group plans, Medicaid expansion plans, some association health plans, some large group plans. They've got some different requirements, but will still have to cover preventive services, don't have to cover essential health benefits. And some other plans have different requirements for cessation or other requirements for cessation and preventive services. And essentially what the preventive services requirement says is any treatment or service given an A or B grade by the United States Preventative Services Task Force, or USPSTF, has to be covered without cost sharing. That without cost sharing is also written into the law. So again, not a lot of room for interpretation there. And tobacco cessation is given an A grade for both pharmacotherapy and counseling for all non-pregnant adults. And then pregnant adults get an A for counseling. And so that's the little box screenshot you see here. The one caveat is states are responsible for implementing this. So there can be some variation, especially you can see that in Medicaid expansion plans. You can see that in private insurance plans. And I'm happy to talk more about that later. Back in May of 2014, the Departments of Health and Human Services, Treasury, and Labor issued an FAQ. This is a translational document. Essentially, it translates what the insurance language, it translates the clinical guidelines of the USPSTF into insurance coverage language for providers and for insurers. And essentially what these 3 departments, and these are the 3 departments that regulate tobacco cessation or regulate insurance coverage, at the federal level have said that what preventive services means is that, yes, tobacco cessation should be covered, and everybody should get at least 2 quit attempts a year without cost sharing or prior authorization. And a quit attempt should include at least 4 sessions of individual, group, and phone counseling, and at least 90 days of an FDA medication when prescribed. There are some medications that are over the counter, but typically you get a prescription for them and you can get them without, an individual can get them without cost sharing. So that's the NRT gum, patch, and lozenge. In September 2015, the USPSTF updated its recommendation. They continued to find that smoking cessation treatment got an A grade. USPSTF is currently in the process of updating the recommendation again. The proposed recommendation continue to have the same A grade. Medicaid expansion, our favorite new topic in Missouri, excuse me. Again, it covers all individuals to about, if you're a family of 3, just under $30,000 a year. The federal government pays for most of the benefits, and they do have to cover the essential health benefits, including that cessation benefit. So that's really great that this new population is going to get these services. In other states that have expanded Medicaid, they have seen a measurable increase in the number of people who have who've used tobacco cessation treatment. So that's really exciting, and I think some really exciting things to look forward to in Missouri. Private insurance, and I'm just going to go quickly through these slides because I think there's some other great stuff towards the end. Most people have employer-sponsored insurance. There is a trend towards self-insured plans, which are regulated by the Department of Labor, which means that they're not regulated terribly closely. So just as something to keep in mind, the enforcement mechanism on some of those self-insured plans can be a little bit hazy. The individual market, so these are people that go to the exchange or healthcare.gov to access healthcare and buy healthcare. There's a couple of different types of financial assistance available to these individuals and families. So premium assistance, which actually cuts down how much you pay for your premium, is available to people to about 400% of federal poverty. Additionally, there are cost sharing subsidies or CSRs. And these go to from 100 to 250% of the federal poverty level. This essentially reduces out-of-pocket costs. So copays, deductible, that's what that decreases. So it really makes coverage and at the point of care more affordable. And those were also required to cover tobacco cessation. Again, association health plans, some are required to cover essential health benefits, some aren't, so it's very confusing. It's a very unsure regulatory environment. And then short-term limited duration plans, these plans don't have to cover anything. So they can be very bad from a tobacco cessation perspective and can limit the amount of care an individual can receive. And then lastly, just to kind of quickly touch on federally qualified health centers, recognizing that that's an access point for a number of tobacco users. Tobacco cessation counseling is a reimbursable service through FQHCs. And the way that FQHCs are paid is a little bit different from the way other hospital settings are paid. So it's just important to kind of recognize that if you do work in an FQHC environment, or if that's kind of where you want to, what your goal is. They're paid on a prospective payment system as opposed to more of the fee-for-service, the traditional way we think of healthcare being paid for. So just, again, not a big deal, still covered, still an available treatment, but I think just some key things to remember when we think about FQHCs. So now I'm going to talk a little bit about some considerations for implementation and some quality measures. I'm totally a dork when it comes to quality measures. I think they're one of the coolest things. Quality measures essentially are about figuring out ways to incentivize providers, health systems to promote quality care and improve that care. And it's this idea of switching, and I think we'll get to a slide in a minute that shows about kind of over the last 10 or so years, there's been a push from, at least from the federal government's perspective, and in different pieces of legislation to kind of go to more than 15 now, more than 10 now, but to kind of go from a volume-based care to a value-based care. So the next slide, sorry, I keep hitting the wrong button. So again, how do quality measures drive care? So typically these quality measures, so you've got to measure either process outcomes or patient outcomes. But essentially, what gets measured gets done, and what gets paid for gets done. So a lot of these quality measures are then going to be tied to reimbursement. And that, so to kind of, again, move from just reimbursing value or volume, excuse me. So the number of services an individual provider does, or a number of services an individual health system does, to how well did they do it, and really kind of incentivizing how well a provider or health system did, as opposed to just what they did. Oh, shoot. That was my fun slide. Okay, so this is the slide that kind of shows, again, for the last decade or so, here are some key pieces of legislation and key regulations that have happened, again, to really move that needle from paying for volume to paying for value. And I think it really started when, if you look at the American Recovery and Reinvestment Act, or ARA, back in February of 2009, which from that spun out electronic health records. And part of that was, are you meaningfully using them? So there were these different meaningful use stages that different provider groups and hospitals had to, show that they were meaningfully using electronic health records to get financial incentives. And by the time we get to April of 2015, we've got MACRA, which will actually negatively disincentivize people for not doing them. So Medicaid payments can actually be withheld from providers if they don't meet certain metrics. And there's a couple of, we could speak for an hour on that, so I'm not going to do that, but there are a couple of different programs that a provider or hospital system can go into. Again, this just goes into a little bit more detail about what I was saying before around meaningful use, making sure that people are using this technology in a meaningful way, meaning that they have to continue to meet different metrics and show that they're actually doing things. One of the things related to tobacco was to ask every patient, at least in meaningful use stages 1 and 2, was to ask every patient ages 13 and older if they smoked was the metric. And so you had to make sure that you could document that you were asking a certain percentage of your patients that question. Again, MACRA, which is the Medicare Access and CHIP Reauthorization Act. It sets up a new payment framework, but again, continues to focus on value rather than volume. And this did replace the meaningful use framework. But again, it both provides bonus payments, but also does penalize providers that are unable to meet those certain requirements. And there's a couple of different tracks, and it recognizes, none of these systems are perfect, but it does recognize that people are in different places. And we've got a lot more resources. The Lung Association's got a fact sheet. And then there's also the Million Hearts Tobacco Cessation Change Package that I'd encourage you to look at. And lastly, and then community hospital benefit requirements. And so again, this is, the Lung Association is a tool about how you can tie in tobacco cessation with community hospital benefit requirements. But there was a big shift pre and post ACA. And, kind of the idea that for a hospital to maintain its nonprofit status, they have to provide a community benefit. Historically, that has been uncompensated care. However, post ACA, there's been really a move in theory, because if a state expanded Medicaid, there was no longer going to be a coverage gap. So the amount of uncompensated care would dramatically go down. So really to get that community benefit outside of the 4 walls of the hospital. And so there's a lot of really cool things that you can look at to work on that. So we'll continue. I know I'm almost out of time. And now just want to quickly talk about tobacco cessation, COVID, and telehealth. And I will go real quick through these. So telehealth, there's the 3-pronged approach from the Lung Association's perspective. First, obviously, telehealth limits patient exposure to COVID-19 while still allowing them to access to their normal healthcare coverage, whether that be tobacco cessation, asthma treatment, treatment for their diabetes, whatever that underlying health condition may be. Additionally, it protects providers and other patients that require in-person care from being unnecessarily exposed to COVID-19. And then the last thing to really keep in mind when we talk about telehealth is to really understand that not everybody's got the access to broadband or the technology literacy to use it. So just to be mindful of that. In the current telehealth landscape, we have emergency waivers. Again, I can get into this, and I'm happy to share the slides in more detail in the Q&A. A number of these waivers have been used in the Medicare program. A couple of key things to just note: some telehealth services can be provided audio only, including our 2 tobacco cessation counseling codes, 99406 and 99407. So that's really important. The other 2 things just to quickly mention here are that patients and providers can utilize these services from their homes as the originating sites. And the Medicare has waived the licensure requirement. So you can waive into another state as long as you're licensed at that level. Medicaid is very different. Each state Medicaid program can do what they want. You can read kind of what is going on here. Private insurance, similar to the cessation coverage, there aren't really a lot of federal requirements, but most states have expanded telehealth, or at least publicly have said that. And here's my contact information. And now I am happy to turn it over to Rick.
Thank you so much, Anne. Now we are going to hear from Rick Cagan, who is the director of the Behavioral Health Tobacco Project over at the National Alliance for Mental Illness, Kansas.
Well, thank you very much. It's good to be with you all and to hopefully learn a little more about what's going on in Missouri, and certainly happy to share information with you about some of our work in Kansas, which involves some of the folks who are on the call today. I see you're on this slide that says cohort overview, which I'll come to in a minute. My purpose really here in the next few minutes is to introduce you to the work of the Behavioral Health Tobacco Project that's sponsored by NAMI Kansas, but it's really a collaboration involving a lot of partner organizations with funding from the Kansas Health Foundation. And so on this cohort slide, you can see initially the 7 organizations that were funded by the Health Foundation in 2016 to focus on moving the needle on tobacco use on the part of individuals with behavioral health disorders. And both Kim Richter and I, who are on the call today, have been quite involved in this, along with 5 organizations that are functioning at the local level. The next slide, if you would, Behavioral Health Tobacco Working Group. This represents a number of organizations, advocacy partners and state agencies, some statewide associations that we are working with, and which constitute our stakeholder group that we call the Behavioral Health Tobacco Working Group. Next slide. So, given kind of where we started in 2016, this represents some of our goals at the time. We've taken an approach to add value to the work, first of all, being carried out by other organizations, and to serve as a catalyst for some cultural changes needed among provider organizations and patients. Since 2016, we will come back to some of these in more detail, but we created the Tobacco Guideline for Behavioral Healthcare, which outlines core components of comprehensive tobacco treatment. We set up an endorsement process for associations and individual programs relative to the guideline, and created a couple of companion documents, a self-assessment tool and an implementation toolkit to help people work through the strategies and the guidelines, which we'll look at a little bit. We've got quite a few local programs and state associations that have endorsed the guidelines, along with a couple of state agencies. In 2018, we championed successful legislation to expand Medicaid coverage that ended up providing unlimited cessation counseling and 4 annual rounds of solo or combination therapy for all the FDA approved medications. We organized or developed rather some online training focused on reimbursement, billing procedures and such for tobacco treatment. And we can go to the next slide then. So, this represents some of Kim Richter's work in partnership with our working group. A survey was done in 2016 that found that 83% of behavioral health programs actually identify tobacco users, but only 20% provide evidence-based care, such as counseling, and only 25% provide medication support. Only 11% had written policies requiring staff to offer cessation services, and only 4% actually receive reimbursement for treatment. We can go to the next slide that outlines the major sections of our Kansas Tobacco Guideline for Behavioral Health Care. By the way, in the chat, prior to taking the mic here, I provided a link where you can find some of these documents that I'm referring to, particularly the Tobacco Guideline for Behavioral Health Care, as well as the companion documents that we'll talk about. But the guideline that we've referenced here really represents a set of 12 essential strategies for providers to support their clients who are motivated to end their tobacco use. And it's evolved through several iterations, but is now pretty well established. And it covers these 4 areas, which we'll go into a little more detail. But first, I want to kind of look at just quickly a little information about the endorsements. We have broad support among our community mental health centers. We're still working on getting similar buy-in from addiction treatment providers and primary care providers. So that's some of our key work. Our state behavioral health agency and our state public health agency have both endorsed the guideline. The Kansas Department for Aging and Disability Services will serve as the home for the guideline and as a repository for documents that we create through this project. And in our home health program run by the Kansas Department of Health and Environment, the tobacco guideline has been established as a criteria for organizations seeking to become providers. Now, if we go to the next slide, we'll do a quick overview here of each of the sections. This first section includes some strategies focused on approaches to integrating cessation treatment into other clinical practices. And it's really asking providers to persist with their assessment and treatment interventions until quit attempts are successful, even though that might take 8, 10, 12, 15 quit attempts. And it really calls us to view tobacco treatment as part of the continuum of approaches to wellness and recovery to measure our progress over time and improve the quality of our interventions. Next slide, which looks at section 2, is really focused on staff capacity, and training is a key component. Kim will address that, I'm sure, in her presentation. We're certainly supportive of all of that work. And I think one of the things we have to recognize is because there are significant rates of smoking by staff at many of these organizations, this creates barriers to buy-in for a comprehensive smoking cessation program. So going to the next slide, this really highlights the third section of the tobacco guideline around creating a tobacco-free environment. We have a number of organizations in the state who move forward to be examples for others in terms of having a comprehensive policy in place and to fully implement a tobacco-free environment in their organizations. And we'll look briefly at the implementation toolkit, which offers some great resources to help organizations carrying out this objective. We'll go to the next slide, which is section 4, and this really the strategies here are in recognition that, as you know, lifelong nicotine addiction most often begins in adolescence and among young adults, and it really calls us to address the need for interventions and engagement with youth around treatment and prevention strategies. So the next slide speaks to the self-assessment checklist, and along with the tobacco guideline, this can be found at the link that I provided in the chat. This is simply an excerpt which doesn't give you a very good picture, but it's the point that I would like to make is that the self-assessment tool is modeled following the 12 strategies in the tobacco guideline. And so provider agencies can use the tool, which is now an online tool, to estimate the extent to which the strategies are being implemented, to describe how their implementation is taking place, and to identify gaps in addressing tobacco guideline strategies. And it's intended for facilities to use as a baseline measure. And then again, over time, as new staff join the organization and as progress is being made with implementation. The implementation toolkit is a publication which you'll find on our website. The online version is much more robust because all the dozens of links which are in the publication are activated. We also have hard copies of the implementation toolkit, which is about 80 or 90 pages for organizations that have endorsed the tobacco guideline. But this really becomes the resource for organizations to go to once they've endorsed the guideline and are looking to begin their implementation process. They take the self-assessment, determine what their gaps are, and then turn to the resources in this implementation toolkit. We've emphasized with our provider community that this is a voluntary process. There's no set timetable at this point in time for getting to high level of implementation for all of the strategies. The goal is really for the organization to make incremental progress at an acceptable rate and to periodically measure that progress using the self-assessment tool and to respond with targeted program improvements. And so I would just add that this document would not have been possible without substantial help from the Public Health Law Center. This slide is likely hard to read, but the point, and just to go along with what Ann has already covered, is that we try to make with our stakeholders is that generally speaking, all forms of insurance have some level of coverage for tobacco dependence treatment. Some are better than others, and but I think the point is that organizations should engage in providing the treatment and then work on getting staff trained and learn how to proceed with getting paid for doing the work. We can go to the next slide, which talks a little bit about our expanded Medicaid coverage in the state. I referenced this a little bit earlier. We really have the most robust coverage in Kansas Medicaid going back to July 1 of 2018. We had very paltry coverage before that, but a return on investment study, which you can find on our website, was published showing a positive return for expanding the Medicaid benefits, and as a result, the legislature agreed to provide additional funding to support this evidence-based standard of care. So 4 quit attempts, year-round coverage for all the FDA-approved medication. Counseling is available with no annual or lifetime limits. And that includes both individual and group settings. Going to the next slide, just visually, you'll find these on our website as well, but posters that we're using in addition to the previous slide. There was a rack card that we showed. These are posters that agencies can use to get patients' attention about engaging with tobacco treatment. Going to the next slide, you'll find a link on this slide for accessing our online training for navigating the reimbursement maze. You know, much of this is specific to Kansas, but a lot of it is generalizable to other state situations. So those of you who are kind of getting into the process of learning how to bill for tobacco dependence treatment, this is not the be all and end all, but certainly a good place to start. And it's a free online module, and we're working with some of our stakeholders now to kind of develop stronger guidance around best practices around billing. So going to the next to last slide around some of our future directions in our work, certainly looking to support ongoing education and training for healthcare providers. We are hoping to see some efforts in the legislature this coming session to expand coverage mandate in private insurance and the state employee health plan. Broadly speaking, our goals are to increase the number of behavioral health providers and primary care providers who are actively engaged in providing cessation treatment, and to increase the number of adult tobacco users who take advantage of their insurance benefits. So we have a new return on investment study that also shows a positive return toward our objective of this insurance mandate that I've spoken to, and we'll see how that goes. It's a very challenging objective that we've laid out for ourselves. Going to the last slide, and I'll stop here. You have my contact information and a link again back to our resource page, and be happy as time permits to address questions and be a part of your discussion. So thank you very much, and I'll yield to whoever's next.
Thank you so much, Rick. We're going to hear from Dr. Kim Richter now, the director of the UKanQuit program over at the University of Kansas.
Well, it's just great to be here today to speak with you guys. I do want to mention that Rick noted that at the University of Kansas, we do tobacco treatment specialist training, sort of in tandem with the Behavioral Health Tobacco Project. And we were, until recently, providing the University of Massachusetts TTS training, but we have just now developed a mostly online training that we're seeking accreditation for. So very shortly, we should be able to provide accredited tobacco treatment specialist training through the University of Kansas in an asynchronous manner. So keep an eye out for that, and we'd love to have some folks from Missouri in that training. But what I want to talk about now is our work in the hospital, in the University of Kansas Hospital, and in terms of both clinical work and a little bit of research as well. So I am a professor in the Department of Population Health at the University of Kansas School of Medicine, and I also direct UKanQuit at the University of Kansas Hospital. And Genevieve Casey, who is the next speaker, is a counselor, long-term counselor in that service as well, and has also conducted a lot of research with me that I'll be talking to you about. And we treat over 2,000 smokers per year in the hospital, and we also do clinical research, clinical trials, and NIH-funded studies in the hospital on the best way to link patients with care. So I'm going to be talking to you a little bit about both our clinical service and our research. I guess there's maybe a little lag there. There we go. Okay. So I want to talk a little bit about fax referral versus warm handoff for referring tobacco users to the quit line for post-discharge care. It's really important. There have been, now I can't think of the word, pooled clinical trials that have found that really it's very important and effective to initiate tobacco treatment in the hospital, but you have to provide care for at least a month after somebody leaves the hospital in order to get significantly different quit rates. So that post-discharge care is critical. And so how do you get that? If you have counselors in the hospital, how do you extend care into the community? So one way that a lot of hospitals are doing it is through fax referral to the quit line or other forms of referral to their state quit line. And we wanted to look at that compared to a more proactive way of getting people linked with the quit line, which is a warm handoff in the hospital. So I'm going to talk a little bit about that research and some of the lessons learned. And then I'm going to talk a little bit about some more barriers and solutions to care from our own research and others researched in hospital-based tobacco treatment. And then a few tips on paying for treatment in the hospital, which is not easy. Okay, so the study I'm going to describe is called EQUIP, Enhancing Quit Line Use Among Inpatients. And really what we did was compare two different ways of referring people to care after they are discharged from the hospital. So the objectives of this particular study was to compare the effectiveness of these two ways, fax referral versus warm handoff, for linking patients with the quit line so they can keep getting support for smoking cessation after they leave the hospital. Okay, so I'm going to talk a little bit about how UKanQuit, our inpatient service, provides care in the hospital, which is through bedside care and then fax referral for post-discharge care. And then I'm going to talk a little bit about the warm handoff care. So basically, our hospital service, when a nurse does screening, when a patient's admitted to the hospital floor, they ask people about whether they're tobacco users, and they offer to link them with medications while they're in the hospital to keep them comfortable, and then also to refer them to counseling with UKanQuit. So if a patient says, yeah, I'd like to talk to somebody about our tobacco use, or if another provider writes an order for tobacco treatment, then UKanQuit typically goes to the bedside and provides that treatment for them at the bedside. I'll talk a little bit more about what happens there. Since COVID, we've been doing that by phone, and that's been working out very well thanks to the ingenuity of Genevieve and her colleague counselors. We offer fax referral to the quit line, and we request medication script on discharge via the electronic health record. And we also will Volt, which is a sort of like a fancy way of texting providers to encourage them to write that script for discharge medications. And then we do follow-up. So we call patients a month after they leave the hospital to see how they're doing. So you know, this transition in care from seeing a patient in the hospital about their tobacco use and then linking them with care once they leave the hospital it's a bugbear for all hospital care. How do you make sure that whatever they're getting treatment for in the hospital gets followed up on when they leave? Now, a lot of hospitals, well, the hospitals that do provide inpatient care are a lot of them trying to link patients with care with the quit line, usually via fax referral or some kind of electronic referral. But really, it's been found again and again and again that very few patients who even get a fax referral where the quit line gets their information and calls them once they leave the hospital to set up counseling sessions, very few patients actually take the quit line up on that. So how do you make sure people get that critical care once they leave? Another way to do it is through a procedure that's often used in SBIRT, right? Screening, brief intervention, referral to treatment, and that's a warm handoff. And the warm handoff in terms of tobacco quit lines involves in the hospital a counselor getting the patient's phone, calling the quit line, and getting the patient to enroll and get their first counseling session while they're still in the hospital. So how did we test whether fax referral or warm handoff was the best way to link patients with care? What we did was we randomized patients to either get usual care, which is where UKanQuit would go to their bedside, assess their craving withdrawal, arrange for inpatient medications for the patient, which is what we typically do, and then provide brief counseling as we usually do, fill out a fax reform, do discharge planning, and like create a quit plan for the patient and document everything in the EHR. And then fax the patient's information to the quit line so the quit line can call them when they get out of the hospital. That's usual care for UKanQuit. And we compared that to a warm handoff where the UKanQuit counselor would go to the bedside, assess craving withdrawal, and try to adjust their inpatient medication to make sure they're comfortable while they're in the hospital, but then do a warm handoff to the quit line. So call the quit line, say, hey, I've got a patient here who wants to enroll. The patient would enroll, get their first counseling session, and then the counselor could leave the room while all that was happening, and then come back and check in with the patient to say, hey, how did that go? Did you talk about medications? What do you want to do there? Can I help with getting a script on discharge? And then documents everything in the electronic health record. So those were the two kind of conditions. And this was the study design. And you could see patients were randomized to warm handoff and fax. And then with the warm handoff, they'd get this brief intervention. They'd get linked with the quit line for their first session. And then the counselor would check back with them. Whereas with the fax, they get a standard inpatient care with the counselor. And then we would track how many counseling sessions the patient got with a quit line after they left the hospital. And then we do assessments at months 1 and 6. So what did we find? We found that in the warm handoff arm, almost every single patient got enrolled in the quit line, and most got their first quit line session. Whereas when fax referral, when we let the quit line call them after they left the hospital and then connect, about 60% of patients, that's still a very high rate, but only about 60% of patients actually got enrolled in the quit line. However, when we looked at quit rates at 6 months, we did biochemically verified quit rates, and only about 25% of people in each arm were quit, and that didn't differ by arm. So we've got basically the same quit rates. And this is very high for a very light touch. This is a very minimal intervention, really. It's just one session in the hospital, and then the quit line takes over from there. That's really terrific quit rates for one shot of intervention. Now, we did find that patients in the warm handoff arm, and that's the red bars there, people got more counseling sessions, which is great. So they were engaging more with the quit line. So what do we make of this? Well, we realized that practically everyone in the warm handoff arm got enrolled in the quit line, and they got their first counseling session, and that they participated in more quit line calls. Also, the warm handoff took less time from hospital staff to deliver care because the counselor could sort of link them with the quit line and then leave the room. So that would be something easy for a relatively untrained nurse or medical assistant to do. So it might be more sustainable and disseminatable because the quit line did all the counseling. Those 25% quit rates were very high for a very sort of low touch intervention. So we think that it was a great demonstration of the feasibility of warm handoff, and perhaps in a way that would facilitate other hospitals to get involved in tobacco treatment. So we can talk more about warm handoff, but I do want to sort of touch on other barriers to inpatient treatment that we found through our research. We've been providing this service since 2006, so we've got many, over a decade worth of experience. And we find that other hospital treatment programs have a number of barriers, and we have faced these as well. Getting referrals for patients is sometimes a difficult thing to do, just getting folks in the hospital to refer to a tobacco treatment service. Getting inpatient medications to patients, we found that only 1 in 5 to 1 in 2 smokers, when we treat them in the hospitals, are actually already on some kind of medication to keep them comfortable. Getting medication scripts for patients when they leave the hospital, that's a very difficult thing to do. Even if you talk directly to their medical resident and talk to their nurse, etc. And they don't even seem to have any contraindications or cautions for medications. Getting that script is difficult, and only 1 out of 3 patients on average leave with a script on discharge, even if they're ready to quit smoking. And paying for inpatient tobacco treatment is, again, difficult. So I'm going to talk about a little bit about each of those. So here are some possible solutions. What we found in UKanQuit is we have EQUIP as an electronic health record, and our IT people have set up a real-time list. So we've got a little place we can go to where when we click on that, we see every single patient that's in the hospital. When they're admitted and they say they're a tobacco user, they go on that list, and when they leave the hospital, they go off that list. So we know where those smokers are, which is great. We get orders from physicians, and sometimes we can get things set up where if a patient has a certain condition like heart failure or COPD, if they are a smoker, then we can get automated referrals for those particular high-risk populations. So you can set up stuff in the EMR to automate some of that referral. You can get increase the rate of inpatient medications. Again, you can create default orders for cessation medications for anybody who shows up as a tobacco user. We've fostered a strong relationship with nurses, and we've gotten text access to prescribers so that when we see a patient, we can text them to request inpatient medication if a patient is uncomfortable and is basically in withdrawal. To facilitate scripts at discharge, you know, the #1 thing that we found that predicted whether somebody left with a prescription at discharge was whether they got medications when they were an inpatient, because that goes through a medication reconciliation process that pharmacists do. And so if they're on something inpatient, then they're very likely to get a prescription for whatever they were on when they leave the hospital, and that's no less true for tobacco cessation medications. And then paying for inpatient treatment, that's a difficult one. I've got a whole nother slide on that right here. Okay, so billing for hospital tobacco treatment is difficult because of the way that that treatment is reimbursed in the hospital. In general, people are paid for by their diagnosis, and that's kind of a bundled payment. And so you can get paid for tobacco treatment. And it may differ depending on whether you've opted into some of those macro reimbursement options that are available now. But in general, you need to get somebody who's qualified to bill for treatment, and then they need to be sent a consult for tobacco treatment, and they need to be in a different service from the resident physician that's caring for that patient. So then that person who's a qualified provider can go to the patient's bedside, do tobacco treatment, bill for the service. Now the reimbursement varies on whether the plan will reimburse for tobacco treatment, so that can vary. But you can recoup some of the costs of inpatient care that way. Another way to do it is by making the case for tobacco treatment in your hospital and getting some kind of general funds for providing tobacco treatment as an essential service. So the reason that the University of Kansas Hospital has opted for 15 years now to provide a contract to our department for inpatient services is that initiating tobacco treatment among inpatients is effective in helping smokers quit. Treating inpatient smokers has been shown to reduce 30-day readmissions, which can cost hospitals a lot of money if they're are higher than the average in terms of inpatient of quick readmissions for some conditions. And treatment reduces hospital costs at 1 year for smokers who got treatment compared to those who did not treatment. And there's a number of studies that I've got listed down there. Okay. So we're on to Genevieve's talk on telemedicine for tobacco dependence.
Thank you, Dr. Richter. Yeah, we will be moving on to Genevieve Casey. She is one of the UKanQuit tobacco treatment specialists over at the University of Kansas.
All right, yes. And I may kind of breeze through things quickly and then go back to things because I tend to elaborate a lot. So I want to make sure we get through everything. But so I'll talk a little bit about why we would do telemedicine, although obviously in current times, as was already mentioned, you know, a lot more folks are doing telemedicine because of COVID. And give an example of UKanQuit was a research study that we did way back when technology wasn't as easy as it is now, as far as telemedicine, and then also just talk a little bit about using it for groups as well. So starting to become reimbursable in some situations, it could improve the counseling quality, and we're thinking over telephone, you know, using televideo is really what we're talking about. So it improves the therapeutic alliance somewhat because you know, you get these visual cues, you can see the person's face, they can see your face. You know, a lot of the counseling that's used for tobacco treatment, there are a lot of pausing and letting somebody think and process through things. A lot of times when people are getting tobacco counseling, they may have not done other types of counseling before. So sometimes those pauses, when we were doing phone only sessions, the patients would occasionally say, "Are you still there?" You know, so when you get the visual cue of you're looking at them and you're nodding, or just like you're leaning forward even, you know, that can be really helpful. Also, just if you do multiple sessions with somebody, it's easier to remember the details when you get the face than rather than just a name and a chart and a voice. So, and then it could potentially increase adherence and impact because of some of those other things. And then as Kim mentioned earlier, you know, that quit lines are underutilized. And so it could be that folks are maybe more willing to do a conversation where they're able to see the person and connect with them more if they're not somebody that likes to talk on the phone. So it could give another option. You know, the other thing I know, of course, now we've really noticed with COVID, but also with transportation sometimes being a barrier for folks. In either rural areas where they're really far from a clinic, or sometimes in urban areas where people don't have transportation other than the bus, then the telemedicine could also be another way around that. So smokers often have lower incomes. So just like not having funds for a bus, you know, for transportation to an appointment could be a barrier. It could also be a barrier as far as having a smartphone or a computer that has internet access or having enough bandwidth. Another thing that we found with phones definitely is that people get out of minutes toward the later part of the month when they run out of funds sometimes, or they may run out of data if they're using a smartphone with data. So that could be an impediment to telemedicine. And then, of course, you know, their phone may be only working or connected part of the time, as may their internet. Also, even if you go with an area that may have access to high-speed internet, the bandwidth might be limited. So in the rural areas, we worked with rural clinics in the study that we'll talk about, and the bandwidth, even at, you know, hospital clinics, was a lot less than what you might anticipate. So sometimes your connection would break up, that kind of thing. The cost of having enough data to have a video connection. Video takes more bandwidth than just text. So you may be able to use your computer to read text and look at things, but you know, when you load a lot of video and when you have moving video, then it takes up more bandwidth. And then poor connections can be a distraction. And this is where the, you know, the older equipment that we used for our study, we actually sometimes in some clinics had to tell a patient to hold the mouse and move it occasionally so they didn't get disconnected. Fortunately, with newer things like Zoom, that is not so much the case. But it still can be if you have poor bandwidth. So just, is there evidence? There is some evidence, not necessarily that it's better than phone, but that it's as good as phone. So I'm not going to spend a lot of time on this, just to say if you wanted to look at some of the research out there, there was this one Cochrane review which found 2 studies that they had enough patients to look at. So quit rates were So 20% for a computer in a doctor's office, 48% for video by phone. And then always when you biochemically verify, they go down a little bit. So it was as good, but not any better than telephone after 6 months in a year. And kind of similar findings. The thing I did think about, though, was similar or interesting about this Australian study is they let them choose what video format. So, you know, that seems like it might overcome some of the barriers as far as people maybe not having the right equipment or the right connectivity. There might be some programs that are easier to access for folks than others, but it then requires your counselors or your team to have all of those programs loaded up. So that might make it a little less smooth in that sense. So video counseling for treating tobacco dependence in rural Kansas physician's office was the UKanQuit study. And like I said, this was a while back, so technology was, for telemedicine, was a little bit newer then. And the reason why there's two logos is we had Spanish speaking counselors trained also. So we had a couple of clinics where we recruited Spanish speakers, so we were trying to get more access to people that maybe not served as often in the rural areas. And then how did it work? So patients were recruited in the physician's office. They were randomized to get either phone or video counseling. So there might be patients at one physician's office getting phone and some other patients at the same office getting video. Phone counseling was delivered at the patient's home, so they didn't have to come to the doctor's office for the phone. The video is delivered in the physician's office. So we had a webcam set up that was installed usually in an exam room. Sometimes there was a spare office, but it was usually an exam room. So it had to be scheduled to be available in that room. Sometimes there were certain days that the exam room was available if a physician was, or a physician's assistant, somebody was only there certain days, or they had, you know, a certain clinic that didn't meet certain days. So that kind of affected availability sometimes. And then we had staff that were trained, and by our telemedicine office, the equipment was set up, and then they were trained how to use the equipment and get folks logged on and started. They got 4 counseling sessions, whichever they were in, the phone or the telemedicine, at week 0, so when they first enrolled, 2, 4, and 8. We focused strongly on pharmacotherapy assistance, so we actually had checked what coverage was for them by a pharmacist, and so they were able to be told, you know, your plan covers these medications. And so they were either, if they were in the phone arm, mailed that the information that they needed, if they needed to fill out a prescription assistance form, if they didn't have coverage by their insurance, or given, you know, what was covered. If they were in the telemedicine arm, that was sent to them. Information could be faxed to the physician's office as well. So strong focus on pharmacotherapy going through, and we'll show you there's a, it really kind of tried to lay out so patients could even look between sessions at some of the pros and cons, and then also talk to the counselors about it. And then, as I said, we were in both Spanish and English. So we used 20 different rural clinics that we recruited patients from. So think about the reach of this, you know, is really improved too, because having an individual counselor at each of those clinics would have been difficult. So being able to reach that many clinics, and then staff screened, consented, and enrolled by phone. We would go over the consent orally and then mail it out to them also. Whoops. And then a baseline assessment and pharmacotherapy guidance. Then they got either their 4 phone sessions or their 4 telemedicine sessions. And then there was a 3-month assessment, 6-month assessment, and 12-month assessment. So I know this is too small to read, but basically, you know, it allowed them to look at each of the medication and kind of look at pros and cons, what the typical dosage was, how long to use it, what side effects and costs to anticipate. So it kind of gave them a little bit of a decision matrix. And then we, the counselors would go over it with the patients, but they would have that in front of them as well in some of their materials. So there was, you can see our little webcam set up on top, what it would look like. So typically the counselor would make a reminder the day before the session by phone. They would also send a email usually to the clinic each week to remind them of the sessions that were coming up. Sometimes there were staff at the clinics that also did reminders. So sometimes they got a reminder both from us and the clinic when that was the case. Patient would check in and go to the telemedicine room. The counselor would call into the computer and conduct a session, and then fax any follow-up material. So we would fax their quit plan that they talked about. We would fax any information if they wanted a certain medication, you know, a note saying, here is the medication, here's what's covered, here's, you know, kind of reviewing that. And then the counselor and patient would work with the receptionist at checkout to set a follow-up for the next session. And then that would repeat. Now, obviously, this says on an ideal day, just to throw out there, you know, in rural clinics, you know, one of the things that would happen is we had a really rough winter, and sometimes people lived a ways away from their clinics. So that can definitely be a barrier to using a doctor's office as opposed to somebody's home technology like their phone, is that then the same things that could get in the way of an in-person appointment at a clinic could get in the way of a telemedicine appointment with a remote counselor. So then just to look at, you know, telemedicine starts out really outperforming just a little bit, but then it starts to kind of balance out, and even phone is a little bit higher at month 12. So people by phone completed more sessions than video. So that travel that I mentioned was one barrier, you know, just the convenience of being able to pick up the phone, or if somebody didn't answer the phone, it was easier to call them again in 15 minutes or an hour. Whereas if somebody didn't make it to the clinic for their appointment time, you know, you have to schedule with the clinic and the equipment in the room. So it might not be quite as easy to reschedule. Again, that would be different if you're using somebody's home phone or home equipment. The video folks used more cessation meds than phone, and we think a big part of that was them being in the doctor's office. They were significantly more to use varenicline, which is of course prescription only, and so having them in the doctor's office where they could get that prescription paperwork filled out. And then satisfaction with the intervention was high in both groups, but people in video, when they were asked if they were likely to recommend the program to others in follow-up surveys, were significantly more likely to do that. So, you know, we think that the, you know, medication, of course, is key to cessation, and the video being integrated into the medical home in that way contributed to the cessation in that arm. So just to switch gears a little bit from the individual telemedicine, we've also have some experience running some telemedicine groups. There was an early pilot group with where we would do kind of similar at a clinic. The staff there would recruit some patients and they would come sit around the table, and then the counselor would be remote here at KU Medical Center. And then more recently, the Masonic Cancer Alliance has several sites that they work with. And so they have several clinics that can call in at one time to a call. So similarly, they have staff that are at the site that recruit the patients and kind of communicate with the patients. But then you have one counselor at the medical center that is connected with multiple sites. So you have kind of like, we have several people here. You'd have, we really felt like 4 sites was the upper limit when you're doing a group, because you've got several people at each site. And you want to be able to see the individuals at your screen. So the way that that worked, we have dedicated telemedicine IT staff, so they were able to identify what equipment works well, identify, you know, any network or firewall issues at individual clinics, which is similar to with our research study. They set up the technology at the clinics and kind of worked with the staff person that's identified at the clinic to help how to use it and troubleshoot. And they would actually be on the call, but not visually there, so that if the clinic was having trouble connected, you know, they could call them up and help troubleshoot that connection. So they provided that support, and they would also provide that support to the counselor if we needed it. And then you would have a staff person at each site that was your contact, that was trained on that equipment. They would be mailed the materials beforehand. You would check in with them kind of on how many people signed up and send them a few more packets of materials than what had signed up, so that if you had a few folks show up at the last minute, they would have those materials, and then communicate to them about availability and reminders. So they would kind of check in with people on whether they were going to come. The group participants would talk with actually those clinic staff if something came up where they couldn't make it, but yes, I do plan to come next week. They would also do the advertising, but we would send them the advertising about the group and the times. So as I said, any more than 4 sites at once would be a little harder to manage with the group. And one of the things that we did learn is what equipment you use makes a difference on how many people in a group can participate at any one site. Because if you have equipment that doesn't have little sound pods kind of placed out multiple places, if you just have a camera that has one microphone on it, then if you get too many people or folks spaced out too much, then the folks in the back row, like I had one particular site where, there was just a gentleman that just didn't speak loud and you couldn't hear him. He sat in the back row, and, sometimes you try to get people, why don't you move up front? And, some people don't want to sit up front, right? So anyways, having equipment, if you can, that has more than one microphone for participants is definitely helpful for allowing more people to participate at each site. And the good thing about doing groups, and when people try to do tobacco treatment groups in person, often they don't have good attendance consistently. You might have a bunch of people sometimes, but that people can't make it every week. So if that's the case at a particular site and you've got 1 person or 2 people showing up, they would have people from the other sites to interact with and get a little bit richer experience. So that was a nice thing about doing groups with multiple sites. So we don't have a lot of experience with billing for telemedicine because we've done it as research study, and then MCA is funded. So, but basically doctors are trying to figure out how to bill for it. And it sounds like basically there's not a standard right now. This is new to folks. And so sometimes people have to try a code and it gets billed, and sometimes they, find that it's not. So it's something, unfortunately, we're still learning about. So real-time video counseling is feasible. It's as effective as phone. And the one study found, it was more effective than just written materials, self-help groups. Patients like the face-to-face of video counseling. I can say as a counselor, generally we like the face-to-face of video counseling also, being able to pick up on the patient's cues. And for group, it might overcome some attendance barriers, and definitely being able to have multiple sites can just make a richer experience. The cost of computers might limit access, definitely for patients doing things in their own home. And if you have to come to a clinic, then the same transportation issues are a problem. For example, we did MCA groups where people were coming to multiple sites. They were pretty well attended, and then COVID hit right at the beginning of the next session that we were going to run. And so we had to go to doing it at home. And, I ended up with 2 people and then eventually an individual session, because those were all the folks that had the technology at home that had signed up already that were able to do it. And I know I kind of breezed through quickly, so happy to answer questions at the end. And that was our telemedicine team, UKanQuit.
Thank you so much, Genevieve. Lastly, we will hear from Jim Bronner, a community educator and tobacco treatment specialist trainer over at Cox Health in Springfield, Missouri.
Hello, team. Hey, as you can tell, is part of the practice, and I may stop the video. I'm basically in a recovery room waiting for a post-surgery for a relative, and I'm not going to let it stop me from being able to present what we do at Cox Health. But we'll just go ahead to the next screen. I think, I don't know if I was, there we go. I just wanted to kind of flag what we do at Cox Health in Southwest Missouri. We've moved along a line that just promotes multiple areas. This is a video, and you can go to YouTube and find this video. It works well in Southwest Missouri, especially in the Branson area, being in the entertainment industry. The Big Tobacco's legally mandated apology. I presented in schools, and this gets rave reviews from our teens and adolescents who love this video, but it's literally the legally mandated apology from a federal judge in 2017. You may have seen some of that on ads that they were asked to do. I say asked to do, convicted to do, told to do for the apology. But he emphasizes this in the song, and I think it's really crafted well to see that. So just want to encourage you, if you have that opportunity, to look that up, look at it, and see how you could use it in a public presentation. I've presented Rotary Club, Lions Clubs, our lodging industry in the Branson area, and throughout our schools in Southwest Missouri, about 12 large high schools. Next slide. Ann earlier said about no system is perfect, and that's so true. You're going to hear a whole lot of that. Genevieve, I think, covered this slide well. Each client has their own why, and that's up to us to really find what that is, how we can find out what their why, because at the root of that, we're going to find out what is the key to making that personal quit attempt successful, no matter where they are, whether they're low income, homeless, recovery population, three of the most populations that I deal with at Cox Health. Next slide. Good quote here is, and we talk about this, I know Kim talked about their training program. I'm attached to the one at the UMass Med School, but if you've got anyone out there, I would highly recommend you contact UKanQuit and get involved in a program that will help you become certified as a tobacco treatment specialist. In addition to that, UMass Med School offers the same thing, and most of them have gone online, but check out what will help you. Next slide. I'd like now if you could just tap this one up and go ahead and play this video. It's an example of what we do in order to promote that and how we do that through our system.
John Denny of Branson has been a lifelong tobacco user.
I started smoking when I was around 10 or 11. The older I got, the stronger the addiction got, the more I used.
Before he realized it, John was hooked.
One day you decide, I'm not going to do this, and you can't. You're a junkie. You're a junkie, man. Whether you want to admit it or not, you are, to nicotine.
He was once active and athletic, but tobacco eventually took a toll on his health.
I've had 5 heart attacks, and I went back to smoking and dipping. I was in the hospital for 2 weeks, dead. They put me in a coma. I come out, 3 or 4 days later, I'm smoking. You think this isn't an addiction?
More determined than ever to face this addictive beast head-on, John enrolled in a smoking cessation program at Cox Health.
One of the things that Jim said is, you have to make a decision to take your mind back over, because you're led around by a little chain of tobacco. In 9 months, it explains to you on the video, how everything's going to change, and it will. I've quit before.
At Cox Health, we are on a mission to discover each person's why, no matter what it is, in order to be the best we can for them.
No, my little grandson's my world. I have a beautiful daughter. I've got a strapping son. Good God. I have a great wife. But my grandson right now, man, he's the fire that lives within me. I can't wait for him to wake up. I want to be around.
Ready to quit? Learn more at coxhealth.com.
Jill said to ask for Zofran. Okay. Are we back? Okay, we do this through our wellness department. It provides the American Lung Association's Freedom from Smoking and represents that. And that's how I got started in this. Another one is at the Martin Center. And some of you that are participating in this right now have gone through the research of that. You were a member of that 8-hospital collaborative at Barnes Jewish that we did last year that went over 18 months. The data is driven by that. And Genevieve did a great job of really staying on track for helping us understand that data and what works and what doesn't. We've created a program. It's 4-session, and it's My Path to a Nicotine-Free Future, kind of open for anything nicotine, and to meet billing requirements of CMS and adapting to so that we can better in the future be more sustainable as far as a quit is concerned, and using tobacco and helping the hospital gain those funding back. Tobacco Free You is a one-time thing that we do. And will build in for referrals to the group quit program. Well, how do we do that? As we move forward, there's other organizations that we can do that. Next slide. Cessation Opportunities, ACEs is the one created by Jenna Wittenberg at MU, and many of you are familiar with that one. You can go online and download that manual, and she's updated the vaping part of that, and that's a good program. Adolescent Quitting Program, Aspire, is video driven. Truth Initiatives has the program This Is Quitting, and it's a great texting program. I highly recommend that. Smokeless Tobacco, Mayo Clinic has one. Kill the Can and My Last Dip are ones that I primarily use. And the earlier part of the year, probably about 50% of my practice was dedicated to dipping. I work with the city of Branson and other city governments to help their employees quit. And a lot of those you'll find fire and police are more in this area of dipping. Smokefree.gov is another one to recommend, and I will, even in class when I'm teaching, bring that one up, get their phone number at their consent, and sign them up for that program. I love the UKanQuit's method of the soft handoff in the hospital to where you can connect them with the quit line, and we're going to really look at that one. That's the next one. And then the last one, partnered with Mayo Clinic, is becomeanx.org. Next slide. We also provide education in the Southwest Missouri schools for vaping, and that's in education, but also for suspension programs. And I will, the American Lung Association, Not on Tobacco, is a new program that is just coming in this fall. You need to check that one out. That will help students not only educate, but also in the suspension programs for being confiscation by teachers in the classroom or coaches, anybody that one of the kids, they're hooked on tobacco or hooked on the nicotine and the vaping. I've already mentioned city government, recovery center classes, low income homeless centers, primary area that I work with. And I'm area businesses, on-site classes. We're in the entertainment industry, of which is a high nicotine use in that area. We also support a free clinic. And one of the ways that we move forward with it is the government housing classes. I just went to the managers of those government housings right before it was put into effect, the law to forbid smoking in these facilities. And it was amazing the response that we got. We were getting anywhere from 7 up to 12 people that would come to a meeting and be introduced to a quit program. So that was very effective for us too at Cox Health. Next slide. We train tobacco treatment specialists there. In fact, we have trained 30 tobacco treatment specialists in the Southwest Missouri region. This is facilitated, and Genevieve kind of talked about that, the telehealth program, but it's enabled us to be able to bring on 1 or maybe 2 other counselors in a group class or an online format that helps us to present and work with clients and be in an open environment. Next slide. Current pandemic adjustments we've made is we use the WebEx and Microsoft Teams. We will continue to do that as we move forward. I usually prefer a live intake and individual counseling at clinic locations that provide these screenings. So we're protected in that way and able to take those intakes, and they've done it safely. It also allows us to use counseling again as 2 or 3 in a team. And next slide. Reaching out, university, one behind, I'm sorry. No one left behind. Seeing the need to provide low cost and no cost opportunities. I literally, we were supported for the first 5 years of the program by the Missouri Foundation for Health, and we raised funds so that we could provide over-the-counter nicotine replacement therapies. When businesses, the Ohio State study that was commissioned by the CDC, when you give them the bulleted points, $5,800 per year per employee by helping them quit tobacco use, they see that loss in the business, it kind of gets their attention. Next slide. And that's what I have. I hope we've left a little bit of time that we can do a Q&A. So I'm going to pass that off. I know I've rushed through this, but y'all have the record of the slides and our information if we can answer any questions for you.
Thank you so much to all of our speakers. And I know that we just have a couple minutes left, and some people have posted questions in the chat box. And so we will send those questions to the speakers. But if anybody would like to ask a question in person now, feel free to take yourself off mute and you can just go ahead and ask it. Raise your hand, and I'll just start off with the first question. You know, Dr. Richter, as you were talking, I very much wondered about us replicating your inpatient work that you're doing. So I'm wondering if you have a protocol that you shared or if you've helped other hospitals to establish what you're doing.
Yes, we have, and we do have a protocol for what we do, and we'd be happy to share that. And one great way to get started, I think, is to you can't do it now with COVID, but we have had people come and just shadow our program and to see how it all works. And we would love for you to do that. You can't do that, but we could talk by telephone. We have a protocol. It would be great maybe if our counselors could talk with people who are interested in adopting it and talk about what they find to be sort of very important aspects of the program to get it started. And we can share the materials that we hand out to patients and have developed. So we'd be happy to.
Great. Anybody want to ask a question before I ask one that's in the chat box? Pause for just a moment. So a question that was asked, I think that is important to all of us is, how does this differ when you're working with patients under the age of 18, right? The work that you're doing right now. And Genevieve and Jim, can I ask you guys that question?
Sure. I mean, for us, we debated a little bit, but because our patients are hospitalized, they basically have we have permission to treat them because they're hospitalized, but because recommendations for medications aren't there for adolescents, you know, but they may have in fact been using for long enough to really be in withdrawal. You know, what we usually do is talk to them and, you know, refer them to the quit lines still. And there's, you know, the texting services that were mentioned that were youth focused. There is a lot more definitely electronic cigarette, you know, vape use with the teenagers. So the few adolescents, you know, we don't get as many referrals for them, but the few adolescents we've talked to, I usually provide those resources. There was a resource for like family members of somebody that vapes that want to help them. So if they're willing to share that with their parents, you know, we would share that with them too. And then when we make our recommendation, you know, usually instead of saying we recommend this, you know, we'll say to the doctor and the pharmacist, you know, there's no recommendation for, you know, medication for adolescents right now. But if this were an adult smoking at this level, this is what we would recommend as far as dosage. Use your clinical judgment. You know, and we kind of talked to the team the same thing, like we can't really recommend medication right now. It hasn't been tested, you know, safety-wise in adolescents. So it's kind of, we give them the information on how long the person's been using, how much they use. You know, a teenager that just started using may be a little different. You know, somebody that's 17 has probably been using since they were 13. They're pretty addicted at this point.
Yeah, I would just add, for whatever value it may be, is that Kansas Medicaid, effective January 1 of next year, will remove the prior authorization requirements for the FDA approved medications for kids under the age of 18. I think, Kim, it's 13 and up, if I remember correctly. So right now, the counseling is available to Kansas Medicaid recipients under the age of 18, and there's prior authorization restrictions, but those will go away for a certain age group beginning next year.
And I've worked with local schools, and as far as a provider intervention or parents, mine are mostly court-ordered or parents that are panicking. And what we do is, and I worked 20 years for a marriage and family counselor, and we heavy on the motivational interviewing, draw that out of them, find out their why, and dig a little deeper, and then provide the opportunity, as Rick has already aptly stated, it's more available, but I use the consent, the parent consent, and I've had one from at least a guardian or a parent in every situation. And you'll find this to be true if you're working with those adolescents. And I had 6 earlier in the year, and all 6 of them had at least that had been caught with the vape 3 other addictions. So we're talking a red flag warning in this situation.
Yeah. And the other thing just to add is most states should be covering, all states should be covering cessation counseling at least as EPSDT, as part of an EPSDT benefit for anybody under the age of 18. Well, 21, but that's a different story, and we can get into EPSDT at a different time. But so there should be at least some baseline of coverage for those Medicaid, those children enrolled in Medicaid or CHIP.
Great. Katie, I know that you had a question about getting a copy of the slides. Did you have an additional question?
Actually, now that you ask, I just, Jim, when you were mentioning the specific program for divergence of kids in high school or even middle school instead of suspension, what organization was that?
That's ours, right?
Oh.
You're talking about not an in-depth, right, Jim, I believe?
That's it. Go ahead and talk about it, Ann, because I'm a part of it.
My colleagues on our health promotion team are much more knowledgeable about it. But Katie, I'm happy to follow up with you and share some information. There's virtual trainings that we're rolling out for both programs. Shoot, yeah, you're really putting me on the spot.
No, that's okay. We can work with the Missouri Academy of Pediatrics. We'll just, we'll work on that and see if there's more communication that we can have with our chapter.
Definitely. And Leah Martin, and I should know, or Sarah Prem, who I believe is on the phone, but we
Okay.
can definitely make a connection.
Okay, thank you.
It is our go-to in Southwest Missouri.
Great. Dr. Everett, I think you had a question as well. I'm not sure if he has taken himself off mute. There we go.
Mainly, it's just amazing to hear the different innovations and the strategies that you've moved towards. And I was wondering if you can share sort of the lessons learned of things that didn't work out as you went along, so some of us don't make the same mistakes as we try to work with our health systems in our clinics.
And who were you thinking of?
Oh, you, Jim,
Okay.
anyone, Rick,
Yeah.
any thoughts that like, don't do this because it just doesn't fly?
Go ahead,
I
Dr.
mean, yeah, I mean, one quick thing is that, you know, the tobacco treatment specialist training that Kim is involved in is really the gold standard. But I think one mistake is that a lot of organizations perceive that anyone who's doing the work needs that TTS credential, when in fact, all the organization needs possibly is one, or perhaps a few, depending on the size of the organization. The rest of the frontline staff can take kind of less intensive training to kind of build their competency for providing the treatment. So I think that's something that a lot of provider organizations are in the process of figuring out.
I can also just talk about the referral piece. You know, one of the things that we've had to do is, so in our hospital, the admitting nurses usually ask about smoking and whether they want to see a tobacco treatment specialist. That's how we get a lot of our requests that aren't the orders from the physicians. And so we've done some training with them on basically how they present that. And are in fact continuing to work on the questions in the medical record were ordered one way that we think doesn't make as much sense. So we think that instead of being asked if they want to see a tobacco treatment specialist and then asked about medication, if you have your choice, ask them if they want medication first and then ask them if they want to see a tobacco treatment specialist, because basically if they want medication but don't want to talk to anyone, they can still talk to somebody about adjusting their dose and getting them comfortable. So it's a way to sell your service, because we see a large percentage of people that weren't ordered or requested. So they didn't say they wanted to see us, but they were on that tobacco user list that was mentioned. And when we go in to see them, even though they've supposedly said no to talking to us, you know, very seldom do we get thrown out of the room. And even when we're calling them on the phone, you know, usually once they see that, you know, I think somebody mentioned using motivational interviewing, that we try to have that motivational interviewing spirit, that collaborative approach with patients, and that we're not there to yell at them for being smokers because they had a heart attack, you know, but instead to say, you know, this is one of the best things you can do for your health. You've heard this before. We're here to be supportive of you and, you know, get you comfortable while you're here and offer you the support you need when you leave. And once they see that that's what's going on, they're willing to talk to us. So the more people that you can get, just that outright referral by kind of asking your assessment questions in the right way and training your staff that do those assessments to present it as, we have this great service we'd like to refer you to, as opposed to saying, you don't want to, you know, talk about your smoking while you're here, do you? You've got too much on your plate, you know, can be really helpful.
I know you all have been proponents of, at least in some of the published literature, of an opt-out approach. Any comments about that, Dr. Richter?
I would just want to follow up, because Dr. Richter, you mentioned that 30% get medication. And so what about that 100% write the prescription, whether they fill it or not? So thank you for asking that, Kevin.
Yeah, so Genevieve is part of this study as well. We just finished recruiting 1,000 patients and randomizing them into either getting opt-out or opt-in care. And so we don't really know how it's going to work. We're just finishing up on follow-up with folks. But it was just really, really interesting because, you know, these we randomly selected smokers in the hospital and made sure that they had a phone we could reach them at, and then we just either did opt-out or opt-in care with them. And with opt-out care, it's sort of like We see that you're a smoker. It's really important to quit. We're going to make sure you get medication to keep you comfortable in the hospital, and then we're going to arrange for a medication on discharge. What do you think you'd be interested in? And then we're going to call you in a few weeks to see how you're doing. And let's talk a little bit about, what your triggers are for smoking. And, folks are never asked, do you want to quit? Would you like for us to call you? Would you like a script on discharge? We just sort of very friendly way, just sort of do it. Or Genevieve does this. And we do track refusals, and somebody has to say no twice to not get their medication script and things like that. So we really don't know how well it's going to work, but it's going to be a very, very good test of preemptively, proactively providing treatment, the way that somebody would around, diabetes or asthma. Like nobody says, you got diabetes, do you want treatment? They say, you got diabetes, what kind of treatment do you want? So sorry.
And just to add to that, we actually did ask them because of the research study if they wanted to quit, but then even if they said no, we still told them we were getting them on medication. They were in that hard. The counselors who are used to doing motivational interviewing, we were very nervous about this, and we thought, well, this isn't what we do. But I mean, it was surprising how many people, even though they told you they didn't want to quit, when you just said she said, this is like your diabetes, you're going to treat it, right? So you're a smoker. And what we do with smokers is we get you on medication to get you comfortable, and we get you something when you leave so that if you need it, you got it, and that was always when people said, okay, you just moved on. And if people said no the first time, the argument the second time was, well, right now you may not feel like you want it, but we want you to have it just in case you do, because that's what's going to give you the best chance of success. So we'll go ahead and ask for it, and a lot of people on that second time around would give in. Now, we don't know yet. Like she said, we haven't analyzed the data, how many of those people filled those prescriptions and that kind of thing. So that'll be interesting to learn.
I think those initial questions asked by providers, if they get a no, when they ask readiness type, then they dismiss any other elements that usually should follow, like a motivational approach.
Mm-hmm.
And instead, if they just go into action by offering supportive type things like medications, even if they refuse, that creates a conversation,
mm-hmm.
and increases possibilities. So I really am intrigued and will be looking forward to your results.
So it's so true in both the research study and in just our hospital program. There are two responses that, could shut a provider down. One is that I don't want to quit, right? I'm not ready. But the other one is I got this, I don't need to talk about it. But for both of those responses, if you keep at it a little bit, well, we offer these things. Is it okay if I go ahead and provide you some education, like for the person that thinks they've got it, about what's available to make sure you do know all the things? Often they continue to engage with you.
Thank you all.
Yeah, thank you to our speakers. Thank you for everybody who stayed on for that extra 15 minutes to get some more Q&A, because there was a lot of really great material here. We will post the recording and send it out to everybody who registered. So much appreciation for your guys' knowledge that you shared.
Bye-bye.
I appreciate everyone's time. Great work.
Thank you.